Yes, sir, we are live.
Uh, Good evening, everybody. First of all, Happy New Year because last session we had live was last year, end of last year. We had a 2 to 3 weeks break. What is before that? It's the end of the year. Uh, uh, Today we are going to discuss about the very important topic that is mass abdomen. In that very specific, all of location mass in the right fossa. I welcome Professor Robinson George from Medical College. Robinson, good evening. I welcome you.
Good evening, sir.
Your presence is very much needed for very fruitful discussion here. I welcome presenter Shahna Shaju from the same medical college. She's final MBBS student. Exam going. Welcome, Shahna. You are going to present mass in the right fossa. I welcome probably Sir Manoharan Sir also will join in due course. And Suresh Chandra sir will join from Varda, he said, later, whenever there are possible, Kishan also might join. But without wasting time, we'll straight away go ahead with the discussion. I welcome all viewers, all students. Please participate and in the interaction and discussion about the mass in the right fossa, which is very, very important topic as far as exam is concerned, and as far as management surgically is concerned also. Very crucial, very common, very important topic as such. So straight away, without wasting time, I think Robin will
Yes,
ask
sir.
Shana, go ahead with your presentation. Thank you.
Yes, sir.
Yes. Good evening. Today I will be presenting a case on the topic Right Iliac Fossa Mass. Coming to the demographic details of the patient, Mr. X, 40-year-old gentleman who is working as a driver, hailing from Alappuzha, Kerala, coming from a middle class family, admitted on 9th of December and examined on 10th of December. Next slide. He presented with chief complaints of fever for 2 days, pain abdomen for 2 days, and loss of appetite for 2 days. Next slide. Coming to the history of presenting illness, patient was asymptomatic 2 days back. Then he presented with complaints of fever and pain abdomen for the past 2 days. Fever was sudden in onset and continuous in nature and is associated with chills and rigors. Fever subsided by taking paracetamol tablets. He also complains of pain in right lower abdomen for 2 days. Pain was sudden in onset, colicky type, intermittent in nature, which was initially a generalized abdominal pain and then localized to lower quadrant of abdomen. Next slide, please. Pain subsided by taking paracetamol tablets, no radiation to other sites, no variation with posture or consumption of food. There was associated loss of appetite, no associated fatigue or weakness. 6 months back, the person had similar episode of fever with chills and pain in right lower abdomen, which was resolved by taking medications. Next slide. No history of black colored stools, blood in stools, constipation, or diarrhea. No history of chronic cough, weight loss, or evening rise of temperature. No history of bloating or abdominal distension. No history of nausea and vomiting. No history of blood in urine, increased frequency of micturition or burning micturition. No history of anemia or any blood transfusion. No history of jaundice. No history of any other swellings in the body. Next slide. Coming to past medical history, no history of hypertension, diabetes mellitus, or dyslipidemia, no history of asthma or tuberculosis, past surgical history, no history of any previous surgeries. Next slide. Coming to the family history, no significant family history, no history of any malignancies in the family. Next slide. Personal history, he consumes mixed diet, has decreased appetite, adequate sleep, difficulty in passing stools, regular bladder habits, occasionally alcoholic, no history of smoking, no history of any allergies. Next slide. Coming to the summary after the history, 40-year-old gentleman presented with complaints of fever and pain in right lower quadrant of abdomen for the past 2 days. Fever was sudden in onset, continuous in nature, and associated with chills and rigors. Pain was colicky, intermittent type, initially a generalized abdominal pain and then localized to right iliac fossa. There was associated loss of appetite.
Uh,
This
okay.
is patient.
Robin will just discuss about the history.
History. Yes, sir. Shreya, can we go to the first slide?
First slide. Okay, next slide.
Good evening, Dr. Divya Baladi. I think he's come, I think joined.
Divya, good evening.
Good
Divya,
evening, sir.
good evening. Divya, good
Good
evening.
evening.
Uh, have a fever, you said, then pain abdomen, you said, loss of appetite, 2 days. What it meant for you?
So the patient had loss of appetite for the past 2 days associated with these symptoms.
So for
So
someone
he was
not
not
breathing.
able to take food appropriately.
Okay. We'll go to next slide, Robin.
Yes, sir. Yes. Shahna, what is the significance of asking these symptoms, that is fever, abdominal pain, and loss of appetite, which is also known as anorexia, right?
Yes, sir.
What is the significance in chronological order?
Sir, in the significance of chronological order is that we have to understand which symptoms comes first. So either
For
we
example,
can,
like for instance,
for instance, if fever comes first and then pain abdomen, so
hmm,
there.
Means what?
Uh,
Here you are
because is it
saying,
possible? Is it possible that both the symptoms will happen at the same time? That's what we are asking, or is something else will happen first and then the other one comes?
Sir,
What
either
is
if the abdominal pain comes first associated with fever, then we can suspect of any abscess formation.
Murphy's triad?
So Murphy's triad is mainly pain, vomiting, and fever.
Yeah. So which one comes first?
Uh, sub pain.
Pain comes first, vomiting comes second, then the other one. Yes.
Yes, sir.
Temperature. Yeah. So PVT. It is very easy to remember Murphy's triad that way. So whenever you present a case, keep something in mind, so that because at the same time it's very difficult that the patient. I think I've seen this patient. So the patient came to the OPD with some sort of discomfort in the right iliac region, like right lower quadrant, and the patient had anorexia. Patient had vomiting since few days, just 2 days prior to coming, but this discomfort has been there since almost a week. Then okay, you got the point, right?
Yes,
The
sir.
temperature
Yes.
came. The temperature came later, so you should know that PVT, the pain vomiting temperature. That you should know that. Okay, the pain also can be as discomfort, abdominal discomfort.
Okay, sir.
Obviously, swelling they will not know, but in this particular case, it is very interesting because this young patient actually he went to the gym. He went to the gym and he thought that it's because of muscular spasm, and one portion of his abdomen was swollen and the other one was half. So he had done some abdominal crunches. I remember this patient. So that history taking is very important here.
yeah, that whether he has told specifically whether mass is he could feel the
Yeah.
mass, he could anything he has told during history, Shana.
No, sir. No, sir. He didn't say about any mask. He didn't get any mask, sir.
Whether he was on any antibiotic during these days. He said he took paracetamol on his own or
No, sir. He consulted a nearby hospital
okay,
for fever mainly, and as sir said, he thought the abdominal pain might be due to the abdominal crunches. Uh, so
okay,
he didn't give much importance to abdominal pain. So he consulted hospital for fever and took the paracetamol tablets.
okay. Now you said the sudden in onset colicky in nature, then
Yes.
intermittent in nature. You said which was initially generalized, then localized right lower quadrant. What exactly you meant? Colicky, intermittent, generalized, everything. Then localized. You said everything you have put in a single sentence. So is it a that is what exactly he told or
Sir, I have to ask him how the pain started, whether it was generalized or if it was localized to one side. So first he told initially the pain started as a generalized abdominal pain and then localized to right lower side.
Okay. Why that confusion arises in many of these such patients, especially in suppose it's appendicitis, because initially they will have some confusion, then eventually they get cleared where exactly is the pain. So, sir, Ahmed sir, good evening, sir. Sir
Manoharan sir,
Manoharan
good
sir,
evening.
good evening, sir. Sir has joined. Okay, sir, we just started, sir. Okay, tell me, Shahna.
Sorry, sir.
That's what why it is why this that happens. Initially, there will be sudden severe pain, generalized, and eventually it get localized to one quadrant.
Sir, as the disease progresses, the pain will be localized to one side.
Okay, okay. Why there is vomiting in this patient? There is no vomiting, is it?
No, sir, no vomiting.
Suppose if patient develops vomiting, what is the cause? Because you said pain is in the lower abdomen. Why they should develop vomiting at all? What possible reasons you think of?
So vomiting can be due to reflex pylorospasm.
Okay.
Uh, in case of any intestinal
Okay.
obstructions.
These are the two possibilities you will think. Probably spasm and or pylorospasm or any colicky pain or any intestinal obstruction of whatever the cause which you are not yet come into conclusion because you are just on the history track. Okay, that is right. And so no permitting you said. Okay, so we'll go to the next slide, Robin.
Yes, sir. Just to clarify, Shreya, can we go to the previous slide? Shana, when you present a case, be very specific. Now, the fever is fine. The complaints for the past 2 days, you have given us the reasons for it. The pain is very important in this particular case. The site of the pain, which you have to be very specific first. You explain to describe the extent of it later. Where was it now?
Yeah, that's
Was it in the right lower quadrant? Now, initially the pain was somewhere else that you haven't mentioned. It's a generalized abdominal pain. Was it around the umbilical region?
you know that
Or not?
referred pain,
In,
migration of
yeah,
pain.
then did it go? That is what sir was asking. Why did you ask it specifically? So the difference between somatic pain and visceral pain.
Uh,
Yes.
what is referred pain? What is migration of pain? There are so many terminologies. Shifting of the pain, referred pain, migration of pain, radiation of pain. All confusing. This one, you know that meanings of this each terminology are clinically very relevant. You should have a very clear idea. So whether it is a referred pain in this you are telling to that history, whether you understood it as a radiating pain, whether you understood as a migration of pain, whether you understood as a shifting of the pain. So even though whatever the answer you are given, so what your this history qualifies to what type of pain among these different types of abdominal pain is important. So get this history or taken the history properly, no doubt about it. But it qualifies to what nature of pain, what type of pain
Referred pain, sir.
referred pain. That's why initially you'll have a diffuse pain, then it get localized. So you should know the meanings of all these different types. I hope you can always read it. Migration of pain, then radiation of pain. Pancreatitis is a good example. Then referred pain again in appendix. It is referred pain occurs both and shifting of the pain also occurs in appendicitis. So like that, all those different confusing terminologies, I think all students should have a very clear idea. I think Robin, I,
Yes,
uh,
sir.
they should have a clear idea. They should always can go to the book and clarify, but will have a very clear pictured idea about these different terminologies. So when they take the history, they should be able to judge themselves that this patient is having this type of the pain. Understood? So this way all these terminologies are important. So that put it over that and tell this is what exactly this. Okay. So we'll go to
പിന്നെ
the next.
ഇതില് onset of the pain, then type of pain you have described it in two ways. So it's colicky on one side and intermittent. അപ്പോൾ it's the same thing, no? Intermittent വരുന്നു പോകുന്നു, waxing, veiny, coming, going on, off. അല്ലേ? Colicky,
Yes.
colicky you're trying to tell us to be a bit more specific.
Uh, yes, sir.
What are the
Like
what are the
grasping.
differential diagnosis for colicky type of pain in the abdomen?
Sir, any kind of colics like ureteric colic, biliary colic.
what is the typical example of radiation of pain?
Sir, in ureteric colic, we'll have loin to groin pain,
Okay.
and also if there is any diaphragmatic irritation, we'll have shoulder pain.
That is
Will
actually
that be
referred pain.
radiation or referred pain? There's a
Referred pain.
difference
That
between
is
the two.
referred pain, no? Right.
Yes, sir. In diaphragmatic, it is referred pain. In renal colic, it's from loin to groin.
Pain, we
And
use the
also,
word
sir,
radiates, with both radiation and referred pain actually. Now, typical
sir,
example of
in
radiation of pain is pancreatitis. Okay.
sir,
And
also in appendicitis, we'll have pain radiating to the left iliac fossa.
that also radiates with left fossa. Occasionally, retrocecal appendicitis pain radiates to the back actually because of the psoas spasm. So that time they will have a radiation. That's agreed, accepted. Okay. So no variation with the posture or consumption of food. Right? Why I put this sentence specifically? Keeping what in
Sir,
mind?
I have asked to rule out any chance of ulcer, sir. Gastric ulcer or duodenal ulcer.
Okay.
The pain will aggravate by consumption of food.
What about posture?
Sir, any kind of, if the patient is lying on the
No, no, no.
affected side,
Very,
Posture.
just give us the differential. Why did you say posture? You have said now when you said consumption of food, you have said duodenal or gastric ulcer. We have no doubt. Very good. Why did you say the other one?
sir, in any kind of peritonitis or if any peritoneal inflammation, if the person lies
Is
on
it
that side,
any peritoneal inflammation in every form? That will be a generalized pain. No, patient will not move. He'll be sitting. It's silent. He'll be sitting. No, but with posture. Are you talking about pancreas?
pancreas also, sir.
Which posture they will prefer in pancreatitis?
Uh, they will prefer like sitting and leaning forward position.
Okay, then pain will subside. Okay.
Mm.
There
Yeah.
was associated loss of appetite, no associated fatigue or weakness. So,
Uh,
okay,
that was mainly to signify that a loss of appetite was only for 2 days, so there was no associated fatigue or weakness.
okay, okay. Not that fatigue weakness because it is not that severe. That's what it is. Yeah. The first appendicitis with the peritonitis, even if it's 2 days, they will have a severe weakness, and once the toxic symptoms appear, they will have. Understood? So it is not very severe, whatever it is. But if you think appendicitis is not formed peritonitis or whatever that acute complications, okay, that's what exactly it means. So 6 month person had similar episode of fever and chills and pain in the right lower abdomen, which was resolved by taking medications. Okay, so what sort of medications patient has taken?
He told he has taken some analgesics.
Not antibiotics, or he whether
No,
he
sir,
got
no, no,
admitted, he
no
got admitted,
antibiotics. He had taken
whether
analgesics.
he had any IV fluids or anything.
No, sir.
That means what? He didn't have antibiotic. He didn't have IV fluids. He didn't got admitted. What means what?
Sir, he was having fever with chills 6 months back. So he went to a nearby hospital and consulted for fever. So they gave him,
Okay, then that no, that means because it was not that severe, because it has
yes,
subsided without any antibiotic, without any fluid or IV antibiotics. That means it was not that severe episode. Whether it's relevant to this condition or something else, also we are not sure. So with
Yes.
just analgesic symptoms have subsided 6 months back. That's what exactly it meant.
Yeah.
So
Yes.
detail history is important. That he has taken antibiotic or not also quite relevant. It is subject to will gives idea about the how severe it is as far as infection or inflammation is concerned. Okay, so we'll go to the next slide, Robin.
Yes. Yes. Yes.
Sir has joined. Sir Manoharan Sir, good evening, sir. He's finding difficult to get the voice. I think we'll continue.
So I think the range is having a problem. In between, he's coming and going. I think it's the internet connection.
Yeah. So no history of black color stools, blood in stool, constipation, and diarrhea. So why this history? You have asked.
sir, if there is any growth in this cecum, I have to rule out that. So in order to rule out that, I have asked if there is any bowel symptoms like altered bowel habits, blood in stools, and
Okay,
melon.
diarrhea.
No history of diarrhea, sir.
Why constipation?
Sir, if there is any intestinal obstructions,
Okay, if we
the
talk.
person can present with
Usually in
constipation.
colon, I'm not questioning your history. You're absolutely right. There's no question you would. Just I'm asking leading question. Obstruction is common in the right side growth or left side growth?
Sir, in left-sided growth, sir.
Why it is so?
Because in left side, most commonly that will be annular or tubular,
Okay, absolutely.
stricturing type. So,
Right side it is a proliferative and the cecum is very accommodative. Obstruction occurs rather late. It too can occur. Not questioning your this one. Absolutely perfect.
So
So no
anatomy
issue.
and pathology. Anatomy wise, the diameter is big on the right side here, and the diameter is smaller.
Smaller.
Here it's ulcerative lesion. Here it is annular or obstructive
stricturing.
lesions.
Sorting type.
Yeah.
So no issue of chronic of weight loss, evening rise of temperature. Why or that?
So this question was mainly to rule out tuberculosis, sir. So
Okay.
any kind of tuberculosis can abdominal tuberculosis can produce this kind of
Kind of
symptoms.
thing,
So
okay. Bloating or abdominal distension.
that was to rule out intestinal obstruction, any kind of intestinal obstruction.
Okay. Any other reason to ask abdominal distension?
Uh, Sir, ascites.
Ascites in acute, yeah. Peritonitis, probably peritonitis or ascites, fluid collection. Agreed, accepted. Why there is no vomiting and nausea? Why you ask that is
Sir, that was Murphy's triad actually in the presenting complaint. So there was no vomiting. So
okay.
that's a significant.
Important. It need not be there always. That's the point. You have to remember. Not every patient should have all components of Murphy's triad, because unless there is a pylorospasm or it goes for a severe type of nearing, goes for a obstructive. You know that obstructive appendicitis, non-obstructive appendicitis. After the time obstructive appendicitis will have a vomiting. Will have a reflex pylorospasm initially, and spasm of the probably ileum also can occur. Whereas when it is non-obstructive type, they may have vomiting. In spite of that, reflex pylorospasm can occur, but need not occur every patient. That's the point you have to remember. So it's not a mandatory part. It's a common factor maybe, but need not be always. Usually, first they will have vomiting, then vomiting subsides. In many acute episodes, if you have seen, initially they say appendix vomiting only once or twice they usually will have. Then eventually only pain and fever, these are the main features. Eventually it becomes like that. So that is absolutely perfect. No history of blood in urine, increased frequency, burning maturation. Why?
Sir, any kind of mass in right-sided mass in cecum can invade bladder, and also the inflamed appendix will irritate the ureter, causing
What
urinary
type
symptoms.
of what type of appendix?
Uh, Sorry, sir.
Which type of
What type
epidemic
of
probably
appendix
So
can
pelvic appendix,
pelvic
appendicitis.
appendix? So the base of it is irritating it, or the tip of it is irritating it.
Tip of it is irritating, sir.
So the tip where it lies, where the symptoms. So if it's a retrocecal, which is the most common, the tip is behind. So all the tenesmus and bowel symptoms are more. When the tip is pointing downwards into the pelvis, the urinary symptoms are more. When such a question is asked, always keep the common things first. Carcinoma cecum with that with infiltration is not very common for undergraduates. They will not keep. So
not
keep common things first.
mass
Yeah,
thing that is not very common. Look,
not
cannot
very common.
not very common. Okay. No history of anemia or any blood transfusion. Keeping what in mind?
Sir, any internal bleeding, the mass can cause any bleeding.
Oh, okay. Anemia is
Okay.
mainly for carcinoma, electrical tuberculosis. Anemia is quite significant. Later on that may be the reason in blood transfusion. But no history of jaundice.
So that question was mainly to rule out the cholecystitis. The distended gallbladder may reach.
Okay. No history of. I'll just keep that one as a. We will not discuss it later. We'll discuss about that later. Because
Yes.
no history of any other swellings in the body. Why that is? Why that history you have asked?
So that was if the mass is any kind of obstructing the lymphatics, then there will be lymph node enlargements, and also certain syndromes can be presented with.
Okay. You are
What
thinking that.
syndromes?
Sir, like Gardner syndrome can be presented with
Okay.
desmoid cyst. So, in
almost
order
all
to
almost all soft tissues, including starting from fat, nervous system, fibrous tissue, including epidermoid, skin, all this, including bone, everything will be there in Gardner syndrome. Gardner syndrome is associated with what type of pathology?
What are the other components?
Gardner's
What main pathology?
FA,
What
so familial
FAP?
adenomatous
It's
polyposis.
polyposis. Okay. What is the other one other than FAP?
Other
It
components of
will be
Gardner.
having FAP, then osteomas of jaw or
No,
mandible.
no, that we've already said. All sorts of tissue, including from skin to bone to everything is
Lymph
involved.
So,
What I
retinal spots.
no, what we want is other than familial adenomatous FAP. What is the other type of tumor that you will find there with polyps? Probably, like what is the other?
It's hereditary non-polyposis
Ah,
called
that yeah, that's it. These are the two types that you will see, which are hereditary in nature. They are autosomal dominant or autosomal recessive.
autosomal dominance.
Uh, what about Gardner syndrome?
Uh, Gardner syndrome, autosomal dominant.
Okay, can you give us the name of one syndrome which is autosomal recessive, probably?
Uh,
Because of all these, that is Hughes-Jaggers Turcot syndrome. You should FAP autosomal dominant. The other one that is HNPCC, that is non-polyposis carcinoma, autosomal dominant, also known as Lynch syndrome, type 1, type 2. Then you have Gardner syndrome, autosomal dominant. Turcot syndrome is autosomal recessive, R for R. It's very easy to remember that. Okay, they will
So,
not ask you too much,
won't,
undergraduates, but because you said no history of any other swellings,
yeah,
so
that's why
yeah,
they won't ask you in detail about it many times because the examiners also may not be able to recollect
yeah,
components.
yeah.
So, but remember the name, that's sufficient. Now, point here is you said only 2 days duration. So, I'm not telling it's not significant. How it is significant? Your anemia and you said only 2 days duration. Then how this becomes significant here?
said
Because you are
the
keeping carcinoma in
presentation may
mind
be
and telling
repeated.
that 2 days duration pain and fever and anemia, no history of anemia because you think it is a carcinoma. So how will you correlate? I'm not questioning your eliciting the history of anemia. That's definitely relevant in any vital fossa mass. But how will you correlate?
So, can you please repeat the question, sir?
Everything is 2 days duration. Am I right? This everything is 2 days duration. Can you hear
Yes.
me?
Yes, sir. Yes.
But you wanted to ask history of anemia and other relevant thing keeping carcinoma in mind. Am I right? So how it become duration 2 days and carcinoma? How will correlate that?
Uh, sir, the
Shreya, I think Manoharan sir's phone is having a range issue. I think that is having causing static.
So that time they'll have fever and pain. So will not be okay, but definitely PG question it is. When they present with the pericolic abscess or pericolic inflammation, then they will say, I got fever, I got pain, 2 day duration, which patient might have had anemia, which might not have noticed. Okay. Sir, good evening, sir. Uh,
Good evening, sir. Some login
sir,
issue.
good evening. Sir, thank you
Yes, sir.
very much
Yes,
for
sir.
Good evening,
joining.
sir.
I,
No, no, no.
I, sir,
Login problem, sir. I'm doing it in half an hour.
I
Great.
know,
Login
sir.
issue.
You are in exam. You are told, but very thankful to you for joining us. Happy
Thank
New
you, sir.
Year
Thank
and
you.
made
Happy
our
New
day,
Year, sir.
sir. Thank you,
Robin,
sir.
Happy New Year.
Happy New Year, sir. Namaskar, sir.
Sir, she is presenting Right Iliac Fossa Mass, sir. We are in the history, sir.
Okay.
Okay. So that's why this is relevant also. Even though 2 days duration, Shahna, it will be useful because many times right-sided colonic growths are asymptomatic. Understood? Understood. Eventually, they may present as acute to pain abdomen. So that's why this
What,
history is
Shana, what is the most common symptom these patients might present with? The right-sided colonic mass.
Uh, so
Because
pain,
anemia is a sign. Would be the symptom?
so fatigue or weakness.
Fatigue. That's it, Madi. Atrolu. Fatigue. Absolutely correct. Because then only you will have to doubt the other thing because he's bleeding. Yes, very okay.
okay.
Sir, any
History of
question? Yeah. So only the jaundice is a little bit tricky. What she has put there
yeah, that's what.
because it is a relation with appendix also. But she said cholecystitis, but all cholecystitis will not have jaundice. So unless it is having obstructive sort of jaundice, the stones, yes. So you should know that it will be
Unless you think it
carcinoma
is
with metastasis.
metastatic malignancy with the mets in metastasis in the liver, and then
Yes, sir.
primary tumor is presenting as acute episode. So then, like
Yes.
that, you have to present, and then that's why you have asked the history of jaundice. So it's a long wind up to explain why you have asked the history of jaundice. But if you write this
Okay.
one, you should be able to give reason why you are eliciting that history. Okay. No
Sure.
history of any other swellings in the body. We already discussed. Next slide will go.
Yes. Yes, sir. Yes.
Yeah. No history of diabetes, dyslipidemia, no history of asthma or tuberculosis. Any other, okay, past medical history, you said 6 months back she had some treatment and with the conservative treatment and without any admission, he has undergone this, what is it? No history of any previous surgeries. Why it is relevant?
Sir, mainly I have asked, there are certain surgeries done which predispose to a cancerous condition, cancerous mass in right side.
Oh, which surgeries will go for? You just enumerate some surgeries which we dispute. Your allegation. You are doing the right away allegation towards me and Robin and Sir Manoharan Sir.
No, sir, actually,
Yes.
urethrosigmoidosis.
Okay, retrosigmoidostomy casting the.
It is a risk
Okay.
factor for carcinoma colon.
But that time, point of time, they'll give the history of all those problems.
But
Uh,
yeah,
Pediatric problem, bladder removal, this one, those all
it's
results
not it's
there.
not very common, Shana. It's when you're undergraduate, so like if you say like this, they will ask a lot of questions. You keep it very simple, very very simple. No history of any previous anything that can predispose it can be relevant to your diagnosis. That should be,
Previous, you can say
you know,
previous procedure. You can keep, that what is the common
yeah.
predisposing factor for carcinoma colon?
Sir,
You know that no adenoma carcinoma sequence polyps.
no family history, sir.
Yeah, family history is important. So we'll come to the family history a little later because
Basic family history, yeah, not surgical history.
any procedure if
Anything,
you put it like that, patient might have undergone colonoscopy earlier, might have undergone polypectomy earlier, or might have undergone colonic surgery for carcinoma colon. And carcinoma colon known to recur in the different way as a de novo disease. One more, understood? No? You know that metachronous synchronous growth. What is the meaning of metachronous growth? Relevant to the carcinoma colon.
synchronous versus
Method,
metachronous.
Synchronous and metachronous.
synchronous lesions are multiple lesions which occur at the same time, and
Yes,
metachronous
yes.
are
But
totally
independent lesions. Independent lesions. And
independent lesions.
metachronicity you have done hemicolectomy, and after few years, after 1 or 2 years, growth occurs, not a spread, but a new disease in the remaining part of the colon. Understood? No? That's a metachronous. So at least that way you can give the answer why you want to ask for the surgeries, rather
Mm.
than telling uretrosigmoidostomy and get confused and lot of questions will come on.
Okay,
So,
sir.
sir, Manoharan sir, anything to ask sir? Right Fossa Mass, she is presenting, and
Sir,
history wise.
anyway, sir, proceed. Please
Oh,
proceed, sir.
okay, sir. Okay. Next slide, Shreya.
So just a point,
Okay.
Shana, because you are, we are sticking to simple things, but you want to stick to very heavy topics like carcinoma colon.
Okay.
Now, is there any past history, anything related to that portion that can predispose the colon to carcinoma? Okay, you think of something like that. If at all you say something like, for example, ileum, where why are carcinomas common? I mean, in that region, why cecum? Obviously, it is some other place also, but what is the anatomical and physiological reason? So that
Sir,
itself
the
will give you proof.
anatomical region is mainly the lymphoid follicles are rich there, the Peyer's
So
patches.
histologically speaking, there's a numerous amount of Peyer's patches. Okay, then
Anything
And also,
gross
anatomical.
gross anatomy.
uh,
What is the difference between that portion of the bowel and some other portion of the bowel?
sir, the difference between cecum and
And the remaining part of the colon, probably descending colon, because transverse colon is a transit part. Usually,
sir,
content would stay there.
mainly the prolonged transit time of food in cecum.
So
Okay.
basically, stasis. This is
Stasis.
the same thing that happens exact parallel from cecum. If you go to the opposite side, there is one another portion which is just like cecum, a junction. This is not a junction, rectosigmoid. There also the thing, angle, na? So you have stasis there also. So the cause of cecum, the carcinomas are same for both the sides. So you have stasis on one side, numerous patches on one side, which reacts to all these bacterial toxins and everything that happened there.
And more
Presence of a competent ileocecal valve, presence of a valve that is there, no, from ileum, that, and it's more liquid in nature. That side is solid in nature. So all these things you should. So whatever is, and what about the bile salts?
bile salts, yeah.
Uh, so bile salts, the cholesterol concentration increases the chance of carcinoma.
Yeah. So any surgeries like something you have done,
Cholecystitis,
cholecystitis,
cholecystectomy.
cholecystectomy.
Vitamin
Ah,
bile
you have
salts.
done the remote. Ah, you're in the gallbladder. Then
More,
bariatric surgery.
more toxic.
Bariatric surgery where you, yeah, removing too much of bowel, massive bowel resection. All these things are coming. So basic, if you know the anatomy and physio, you can answer that question. But again, like sir was saying, you stick to simple things. Your differential diagnosis of basic right iliac, like maybe appendix, ileocecum. Okay, carcinoma is a very long shot. So yeah, be careful when you, yeah.
So next slide will go. Next slide,
Yes, sir,
Shreya.
yes, sir. Next slide.
So you said no significant family history, no history of any malignancies in the family. Okay. Why this any malignancies in the family is important?
So that was to rule out the familial adenomatous polyposis.
Okay. Malignancy. Colonic cancer, you know that, no? I don't know, familial colonic family running in the family, there are different types that is quite significant, important. Colonic malignancy run in family many times. So that is a relevant. There's a three-generation family history in detail you have to ask. So that you have done, I think. And no family significant, you ask. So when they ask this family history, all those polypos, different types they may ask. The relevant thing better to update yourself and keep it in mind. I think that's important. And
Shahna, what is the what you have asked, just to complete it? Like sir was saying, malignancies in the family. You're thinking of some hereditary problem. Agreed.
Yes.
Familial cancer syndromes. Can you give us the name of some criteria that we use to decide this?
criteria, there are, if you know, that's okay. It's a
Just
very
yeah,
type of
just give the name. Give the name.
Amsterdam,
Amsterdam.
Amsterdam
Very good.
criteria,
Yes, yes. Amsterdam criteria. Then
Bethesda.
yes, that's it. That's Madi. Two of them. Amsterdam. You have revised Amsterdam criteria now in the new book.
Modified is
If you read
there.
SRB sir's book,
Criteria is
it
there.
is there. He has given a very good table where the old one is there and the new one is just below that. And upper the side, the bedside criteria. That's it. Nothing. Yeah.
That's it. That's
Very good.
sufficient.
Yeah.
At least keep in mind that it runs in
That's
the
it. Yeah.
family. There are criteria. If you know that much, that is sufficient. Okay. So
Yes.
say next slide. Okay. Personal history, consumes mixed diet, adequate appetite, adequate sleep, difficult in passing stool. He's having difficulty in passing stool, Vivek.
That's a we cannot say it as constipation, sir. He has
Okay.
difficulty in passing stools.
Okay.
So I don't think it's as a constipation.
Okay. And occasionally alcoholic. What is that? Alcoholic is daily. They are addicted to this one. He occasionally consumes alcoholic.
Social drinker
Sir,
or
Somebody is
he
addicted, will tell he is alcoholic. Okay.
sir, he told
No, occasionally alcoholic. Occasionally consumes alcohol. Okay. So it's a technical word. No, if you name somebody alcoholic, he is addicted. So occasionally cannot be alcoholic. Occasionally he can consume alcohol only. Okay. So no history of smoking, no history of any allergies. So we'll go to the next slide.
yes, sir.
So summary
Okay.
said
Summary.
again, pain, colic.
lymphoid swelling of approximately 4 into 5 centimeter size is seen about 5 centimeter lateral to the umbilicus in right iliac fossa. Skin over the swelling appears to be normal. No visible peristalsis or pulsations. No visible scars, dilated veins, or any discoloration of skin. All hernial orifices appears to be normal. Next slide. Palpation. Local rise of temperature and tenderness present and right iliac fossa. Single ovoid mass measuring 5 into 6 centimeter is felt about 6 centimeter infralaterally to the umbilicus in right iliac fossa. Superiorly 6 centimeter below the right costal margin in the midclavicular line, laterally 3 centimeter from the anterior superior iliac spine and medially 2 centimeter from the umbilicus. It has a lobular surface, well-defined borders, irregular margins, and firm in consistency. It is an immobile mass with no transverse or vertical mobility. Does not move with respiration. No pulsations felt over the swelling. No guarding, no muscular rigidity, no rebound tenderness, no tenderness in left iliac fossa. Coming to specific signs, Rovsing signs was absent, leg raising test, swelling becomes less prominent, Hobbs-Swartz test was negative, obturator test was negative, and Baldwin's test was negative. Next slide. Palpation of hernial orifices. All hernial orifices are intact. Examination of regional lymph nodes. No regional lymph nodes were palpable. No supraclavicular lymph node enlargement.
Shreya, can we go to the slides, please?
Next slide. Coming to
Say, we go to the
percussion.
slide. Yeah, free of the percussion.
Percussion, liver span 12 centimeter, dull note over the mass and right iliac fossa, resonant over the rest of the abdomen, flanks are resonant, no shifting dullness or fluid thrill. On auscultation, normal bowel sounds was heard. Examination of external genitalia appears to be normal and rectal examination was not done. Next slide. Coming to the systemic examination, respiratory system, normal vesicular breath sounds heard over lung fields, no added sounds. Cardiovascular system, S1, S2 heard, no murmurs. Central nervous system, no focal neurological deficits, and sensory system normal. Next slide. Coming to the summary after examination, 40-year-old gentleman presented with complaints of fever and pain in right lower quadrant of abdomen for the past 2 days. Fever was sudden in onset, continuous in nature, associated with chills and rigors. Pain was colicky, intermittent type, initially a generalized abdominal pain and then localized to right iliac fossa. There was associated loss of appetite. Next slide, ma'am. On examination of abdomen, an ovoid swelling was seen in right iliac fossa. A single irregularly ovoid mass of size 5 into 6 centimeter is palpated 6 centimeter infralaterally to the umbilicus in right iliac fossa. It has well-defined borders, irregular margins, lobular surface, firm in consistency, and immobile. So coming to the provisional diagnosis, this is a case of right iliac fossa mass, probably an appendicular mass following an acute episode of appendicitis with no complications.
Okay, I will go back to the that we will discuss later. Go back to the palpation slides. Inspection, okay. Inspection, okay.
Inspection. Shreya, go to inspection, please.
This
Yeah,
slide,
yeah.
okay. Uh,
Shahna, on inspection of the abdomen, do we use the term non-distended or some shape, scaphoid, or some raw? We usually use some terms like that, no? We don't use
Scaphoid shape.
non-distended. Yeah, something
Scaphoid,
if it's not,
normal,
yeah,
flat, scaphoid. Then we can specify it is not distended. A
yes,
non-distended abdomen is not. It is you are purposely vague. That's what exactly.
yeah,
So understood. So either scaphoid or flat, you tell, or you tell. Then you can put your specific word. It is not distended because you got some obvious reason to say that why it is not distended properly. Because you are telling that it is not obstructed. That's what exactly you want to inform. So
Yes.
all quadrant moves well equally. Okay, you know the meanings of the quadrants and regions. Regions are different, quadrants are different, and we are not going to detail it. Umbilicus central and inverted. Then you know that sign if it is pushed up or below. What that sign called?
Sir, turn.
No,
Caniol
no, no.
sign.
The first letter is correct, but the rest are not correct. What happened? There are two
Sir,
diagnoses. You have one from below, one from above. So something will push it down, something will push it up. You have to
as a
differentiate. What is
name,
that?
the distension in the upper portion will be
No,
due
no.
to.
What Sir's question is, what is the name of that sign?
Name of that sign.
Sorry, sir, I don't know.
Okay, that is called Caniol sign.
Tanniol sign.
Or below, depending if it is ascites or in ovarian tumor. Okay. So
Yeah.
single wire swelling approximately 4 to 5 cm seen in about 5 cm lateral to the umbilicus in the right iliac fossa. Skin or swelling appears to be normal. Okay, no visible peristalsis or pulsations. Why do you have mentioned that pulsation and visible peristalsis?
Sir, if there is any kind of intestinal obstruction, there will be visible peristalsis present.
Pulsation,
Pulsation. Pulsation.
Pulsation, mainly if there is any mass over the blood vessels.
No, no,
mass
no.
over
Just give
the
us a diagnosis. What is the differential diagnosis for something in right iliac fossa?
pulsatile mass.
Pulsatile
Sir,
mass.
aortic aneurysm.
Aorta comes in the right iliac fossa
Right iliac fossa? Aorta is
in the
here.
midline, no? I just
Midline, no?
talked in the umbilicus, no?
Uh, Sir, any mass over the iliac artery.
Which vessel? Ah, okay. Yeah, iliac artery aneurysm. This side. It splits this way, no?
Mm.
Right side, left
Okay,
side.
iliac artery aneurysm, or if you are thinking suprapubic pulsation, mass compressing that.
Okay.
Visible scar, hereditary vein discoloration, all hernial orifices appears normal. Genitalia you are not mentioned.
Uh, Sir, I
So
have
I think
mentioned
she
You said
mentioned it next
examination.
slide.
palpation, after palpation. Okay.
Separately she yes.
Yeah, yeah, okay, okay. Sir,
Shreya, can we go to the next slide?
yeah, Manohar sir, you want to
Sir,
ask
anything
anything?
in the inspection?
Sir, okay. Palpation, local right angle, okay. Mass is inferior lateral, okay. Superiorly, you said mid-clavicle and lateral, everything you have mentioned. Why you said lobular surface? What is that lobular surface in the abdomen? Is it common other than kidney?
Sir, any cystic swellings will have.
Cystic swelling, there is no cystic swelling in the abdomen other than hydrated cyst because you won't be able to elicit fluctuation. No, cystic disease will be there. Disease with the cystic will clinically you won't tell this is cystic because you can't elicit fluctuation in the abdomen. You know that to say something cystic, you should be able to elicit fluctuation. So you can't elicit
Yes,
fluctuation in the abdomen because why? Why you can't elicit fluctuation in the abdomen?
because of the abdominal muscles.
No, not because you can't fix the swelling. Anything to elicit fluctuation, always your prerequisite is if you have to fix the swelling. If you can't fix the swelling means you can't elicit fluctuation. You can't elicit fluctuation means you can't say clinically that it is cystic. Understood?
Yes.
It may contain fluid. That's a different thing. Clinically, you can't say it is a cystic. That's a simple thing. Other than hydrocyst. cyst. Okay. So I don't know why lobular surface you have told well-defined border, irregular margin that you have told that is okay. Formin consistency is also okay. You should tell the movement with the respiration should come first, then go for the immobility. Always in the
Yes.
abdomen mass, movement with the respiration should come first.
Okay.
After that, you mention about the not mobile. Okay, you
And this
said this
movement with respiration is something that you see first, no? Or inspection also you have to mention.
impression also you
You
have
are
to
see
mention. Okay,
all these in the abdomen, whole thing, superficial and palpable, whatever organs are connected to the diaphragm should move with respiration.
respiration.
Alle, liver,
Okay,
spleen
yeah,
on one side, stomach a little bit, and minimum when you go down, little bit of kidneys. Gallbladder because it's attached to liver, it will move very well with respiration.
that's right.
So when you go in that order, very well that sort of word that should
Oh,
be there first, then does not move. Then, so is it possible that Shahna, are you thinking of something else when you said lobular surface?
You are thinking of
Something.
lobular
Are
surface.
you some
What you
other
are keeping in
differential?
mind? You thought it is lobular surface. If it is so, what other things comes in mind?
Are you suspecting something else other than cyst, which is not possible? Either kidney, polycystic kidney, or hydrosis, which is again not possible. But is there anything else you're suspecting the right iliac fossa having a lobular surface?
Lobular surface.
sir, appendicular mass.
A particular mass, but what will cause a lobular surface?
Why it should become lobular? Its surface may be either smooth or surface may be irregular sometimes. Okay. Why it should be lobular? What it makes lobular?
So due to multiple septa,
Septa will not make
Septa?
it lobular. It will become only firm, no? It
Oh,
will become only firm.
septa. Again, you're talking about some abscess, something is going inside. No. Is it possible that something else may be
so carcinomatous,
lobular surface? Surface will be regular or irregular. These are few terms that we use for surface, no? Ah,
Surface, that's why lobular. Because the moment you say lobular surface, somebody think that it is extending in the lumbar region because you said big mass. Then somebody also will think that it may be related to the kidney, something like that. So when you use surface and surface consistency, movement in the respiration and mobility. So the four things are very relevant. And when you use the words for these four things, you have to use very judicially, very carefully, because these two things, these four findings will define from where mass is arising and what exactly pathological nature may be. All these findings will tell the pathological nature of the whatever the mass. So that's a very relevant when you use these technical clinical words. They are very, very specific. It gives some meaning, some understanding when you use these words. I think Manoharan sir, you will agree. Sir, Robin, you also will agree, I
Yes,
think,
sir.
because
There is
these words are very, very
local local local
yes,
nature,
sir.
sir. And tenderness is there. There will be bleeding also.
Yes, sir. Yes, sir.
So in that case,
So
it is difficult to validate, especially the surface to find that it is. The duration is very short. 2 days, 3 days history as per the history. So globular surface, I do not agree, sir.
yeah,
Depend
good.
what is the
sir,
interval
yes,
margin
sir, sir.
come in country.
Yes, sir, sir. From anatomical point of view, Shahna, we are thinking of few organs in right iliac fossa, which is very common to both male and female. You have
Yeah,
appendix, you have
yeah.
ileum, and you have cecum. Now, the only thing, the points what Sir has mentioned is surface, border, margin, consistency, mobility, movement with respiration. All these things have to do something with that anatomy. Is it a freely mobile structure like an appendix, little bit of ileum, or is it a fixed structure like cecum? And especially if it's carcinoma, depending on the stage, it gets more adherent. So, agreed? Yes. So, if you know the anatomy, it's very easy to figure out this. Next, is it possible that maybe some momentum has come and sat on top of this fellow and has caused this lobularity?
yes, sir. In case of appendicular
Yeah,
mass
yeah.
formation,
But the momentum usually clinically what you see the granular surface, because when some
Yes,
momentum
granular.
that when there is any disease, inflammation or malignancy or inflammation or infiltration, the two things which can happen in the momentum, and this makes it firmer and becomes granular. So it is not natural. It is a normal texture will be lost. So usually we
Yes,
explain it as a granular. So that's why okay. That's why this lobular surface usually we use a guarded specific ideas actually when you say that. Okay.
yes, sir. Yes, yes.
So no pulsations felt or the swelling. We already had the reason. And once it is not mobile, you said it is fixed. Fixed to what? You have to explain. Why it is fixed? Fixed to what?
The point is,
So
the
something is
point
not mobile. You have to tell why it is not mobile.
transfers are mobility.
Sir. Yes, sir.
sir, can
Now
sir,
it
can
is.
you repeat it?
Yeah, yeah. You said it is not mobile. Immobile. That means it is fixed. It is fixed to what? You have to predict at least and tell.
Sir, if it is fixed to the peritoneum
Okay. If it is
and
fixed to the peritoneum, it will have a inflammatory edema. You won't be able to. That's why head rising test will not be. It will be same as, and won't be able to move, feel the abdominal wall and mass separately like that. If it's fixed to the anterior abdominal wall like this, it may be inflammatory. They'll have abdominal edema actually. If it is infiltration, you will feel hardness in the anterior abdominal wall. You won't be able to feel a separate mass. If it is fixed posteriorly, it won't be mobile. It won't be, it will not enable to independent mobility either on either direction. So if it is so, it is either fixed inflammatory process or infiltration. The only two way it can get fixed. So posteriorly, what it gets fixed is important if it is not mobile. So naturally, it is inflammatory process get fixed to the psoas major or retroperitoneum, not anterior retroperitoneum. Okay, that makes it non-mobile. Okay. So that little deeper to UGs, I think, Robin. For PGs, yes,
Yes, sir.
this critical thing
Yes.
they should be able to answer. But
Yes.
if they think
Shana,
it is good,
and whenever you say borders, especially right iliac fossa, you have to be specific, well defined what upper, lower, because the different again the diagnosis is different. When it comes to appendix, what is it? An ileocecal, what is it? Cecum, what is it? And when it comes to a female ovary, pelvis, pelvic masses, so the lower border. What is the common thing, differential diagnosis in both male and female, where you might be able to insinuate your finger between two masses above and below? We have given you clue.
Uh,
Specific. Be specific with the diagnosis. A diagnosis where you can insinuate your finger, because right iliac fossa, now you have something. If I tell you that, it becomes easy.
Sir,
You can
in
put your finger, so there's a swelling somewhere and somewhere. So the border, you'll be able to insinuate. It's in the differential diagnosis for both male or female. You have mentioned something in the history. I mean, it's very important there because you're ruling out some other diagnosis.
uh,
Okay, one more last clue. Supposing the patient had tuberculosis
uh,
and the patient is presenting with mass.
Sir, in tuberculosis, we cannot insinuate finger between the.
Now, what is the diagnosis where you have probably two masses above and below? What is that diagnosis? Tuberculosis. That infection is spreading from behind, not from anywhere else. Not, yeah. In your
Sir,
examination, you had mentioned.
psoas, iliopsoas
It's a
abs.
ileopsoas abscess. It's a, what do you call? You have a cross fluctuation. You have a cross fluctuation. So this is very important where you put your finger for pelvic masses which are rising from there. You are not able to feel the lower border, but the upper border. But the ones which are in the abdomen, you are able to feel the lower border. You have to differentiate a purely intra-abdominal mass like appendix, ileocecum from a pelvic mass. Then the only differential is the psoas abscess, which is having both ileo psoas. Cross fluctuation.
yeah, this is what
Dumbbell tumor.
purely intra-abdominal or retroperitoneal or intra-abdominal. This is what
Yes, you have to know.
that is
Yeah.
it's in percussion also will do the same thing. So
Yes,
good.
yes, sir.
Slide, Robin.
Yes, sir, yes, sir. Yeah, we can go.
Next slide. Okay, you said no guarding, no rigidity, no rebound tenderness, no left iliac fossa, no tenderness. But right iliac fossa tenderness present. You are told earlier only to begin with. No rebound tenderness. You said rousing sign absent. You know that what is rousing sign? I think.
So that is, we have to put pressure in the left iliac fossa, and there will be tenderness in the right iliac fossa.
Okay, leg raising test. What is test called as? Leg raising test.
Uh,
Any name? Just
Sir,
want to. If you know, that's okay.
psoas.
Pope's hour test.
No, no, no. Copses, you have already mentioned copses. That is flexion and extension. What do you
Okay.
call the leg raising test?
Carnet,
Carnage
carnets.
test.
Test. Okay,
Head
Carnage test.
raising or leg raising test.
So
What
it
do
says
you call that? What do you call that test where you press on the right iliac fossa suddenly and you release it and you find something? What do you call that sign?
So once more,
You press at the right iliac fossa suddenly and you leave your finger.
sir, rebound tenderness.
What is the name of that sign? Yes. What is the name of that sign?
what is the name of that sign? Rebound tenderness.
Uh,
There are approximately 10 signs. It is there in SRB Sir's book. At least know the basic five. That is, you have mentioned Rosing's Bloomberg sign, rebound tenderness. Then, depending on the position of the appendix, you have psoas, obturator, retrocecal, and pelvic.
Rebound
Then,
tenderness.
Goldwing's and
Very
Gregg-Lacey.
typical. Rebound tenderness.
Yes.
Bloomberg sign.
I think you have seen in the OP, no? We are always doing that. Any patient comes with the right or iliac, you have seen us doing this, no? We push this
yes.
quickly and release and see.
Release sign or Bloomberg sign.
Release sign or the Bloomberg's rebound tenderness. Yes. Yes, sir. Okay, sir.
Good. Next slide. Okay, all hernia lobes are intact. No regional lymph nodes. Which regional lymph nodes you want to come here in the abdomen? No
So
subclavicular
mainly
lymph node. Okay, great.
the iliac group of lymph nodes.
Very rare, not very common. Okay. I think we
Regional,
can.
because this itself is a region, then
Yeah.
because this itself may be a lymph node mass. You said that while at the end of the history, you said it may be lymph node. This itself may be lymph node mass, and so regional just better to avoid because not supraclavicular lymph node enlargement. What it is called as? Why it is enlargement? Lymph
Troyes
node
signs.
or chose node and troisier sign.
So the patient is having a right iliac fossa problem, no supraclavicular right side or left side lymph node enlargement.
Yeah,
Left
left. You
supraclavicular.
have to specify always. No,
So,
it's only left.
so right side, right problem very rarely that because already there is you have a thoracic, you have lymphatic chain in the right side, lymphatic duct. Thoracic duct is only on the left side. One thing, like sir was saying, this examination of regional lymph nodes. There are three main regions according to the watershed areas of the body. So we generally use that. Cervical region is one. Second, we have axilla. Third one, you have the inguinal region.
Inguinal.
We are not going to waste time here. We're just saying. So those are the regional lymph nodes where things are watershed areas, where it's draining. Always you keep it last, preferably. This you have come in between in palpation and
Unless you think abdominal wall involvement, abdominal wall disease, where wall drains into the inguinal lymph nodes, then you think regional lymph node inflammation. You said it's intra-abdominal mass, then it becomes very tricky to say that there are regional lymph nodes are involved. Okay? So we'll go to next slide.
yes, sir.
Go to next slide. Sir,
Shreya, can we go? Yeah, percussion.
percussion, liver dullness always should be mentioned first. Resonant over the rest of them. Dull note over the mass. Flanks are resonant. No shift in dullness or fluid thrill. Agreed. Normal boysense. No bruit heard. What bruit you want to check?
Sir, systolic bruit.
Where over
Uh,
the mass. If you're over the mass, where you have looked for bruit? Yes, I'm asking.
bruit is in the above umbilicus, sir.
Renal bruit you want to check, is it? Okay. Okay. For completion, we will accept it. The external genitalia is normal. Why it is important?
Sir, in case of any undescended testis can
Okay.
be presented with right iliac fossa mass.
Rectal fossa mass. Okay, great. Sir, sir, Manoharan sir, anything to ask, sir? Questions?
Yes, sir.
Yes. Okay. So we'll go to the next slide. Sir, always remember percussion,
Next
liver
slide, sir,
damage.
next slide.
Yes, sir.
Shahna, just one question. You are free to answer it, or you please note it down somewhere. Can you give us two differential diagnoses? In percussion, you have said something about dull note present somewhere, liver span is present, resonance all over the abdomen, flank. Is there anything called impaired resonance on percussion?
Impaired. See that?
Have you heard of this term, impaired resonance? Have you heard of this term, impaired resonance? That is, have you heard it?
Yes, sir,
Yes or
I've
no?
heard.
Okay. Can you give us two conditions where you have impaired resonance as a differential diagnosis for right iliac fossa?
Impaired resonance.
ഇറ്റ് ഈസ് എന്ന് പറഞ്ഞാൽ മനസ്സിലായില്ലേ റെസനന്റ് ഉണ്ട് പക്ഷെ അല്ല ഉണ്ട് അല്ല അങ്ങനെ
Shana, when you
It's there,
percuss,
but it's not
the
resonance.
entire thing is dull. We presume that bowel is in front. Mass is in front of the bowel. If mass is behind the bowel, then we presume that it is resonant. Now, if mass is arising from the bowel, then we logically consider as what Robin has told as impaired resonant. Understood?
Yes.
So this percussion is very, very important in abdominal mass. It says anatomical exact location in relation to the bowel. Location of the mass in relation to the bowel. Whether it's in front of the bowel, whether it's behind the bowel, whether it's arising from the bowel. That's why Robin has specifically asked what is the exact meaning.
Sir has given you so many clues, so you just have to give the answer now.
Uh,
Just two.
Sir,
Two different.
sir, in any kind of appendicular masses, the intestine will come in front. So we'll have resonant
Appendicular
note.
mass, you have cecum below, appendix which is inflamed and probably perforated, about to perforate on one side. You have coils of the terminal ileum coming on top of it and sitting on, and you have the greater omentum also coming and sitting on top of it. Right? So
Yes.
you have what? Okay, next.
Sir,
Repeat.
in
Hmm.
uh, carcinoma of cecum.
Carcinoma cecum, impaired resonance. You will not get it. You have a mass there, a hard. Sir has already given you all clues. So appendicular mass also you have something sitting on top of your pathology. See a cecum also you have something sitting on top of your anatomy. So both the places it's gone. Now ileocecal tuberculosis, do you find impaired resonance? Is it possible?
Only second thing, okay.
No, sir, because the bowel loops may be adhered.
Now, here what happens in ileocecal tuberculosis is adherence on one side and everything is inflamed. Here what happens is these cecum can get pulled up. That is what that when you read ileocecal, you'll come to know the changes in hyperplastic and ulcerative types of TB. It's very well written in Sir's book. It's very easy to remember. One is getting pulled. There are four signs that you will see also in ileocecal tuberculosis with this. It's very easy to remember also. Okay, for completion. Very good. Okay. You should know this term, huh? Impaired resonance, because Sir was saying resonance is percussion is very important in abdomen.
Percussion is very relevant and
Very important because
we
it comes
say
for liver, spleen, bowel, kidney, all these things. Percussion is there.
yeah. So see, liver comes in front. So it is dull on percussion. Spleen comes in front. It is on percussion. Retrobudal mass, it is behind bowel. So it is resonant on the percussion because you got a
Yes,
bowel with the gas in front. So like that, correlation and analysis will go on when you do the percussion. This percussion is
yes,
very
sir.
relevant. Okay.
Yes,
So
yes.
next slide, Shreya.
No, systemic nothing is there, sir. It's
Yeah,
okay.
next slide. This is the same slide she has put for this one. Next slide.
Diagnosis.
Yeah.
Okay.
It has
Environment
well-defined
conditions.
border, irregular margin. Again, lobular surface. There is a confusion. Again, other things we have discussed. Next slide.
Okay.
So you said appendicular mass following an acute appendicitis with no complication. Okay.
Appendicular mass itself is a
It's
type
a
of, or are you
complication.
talking
No.
about? Yeah.
Appendicular mass
It's,
itself is a complication.
it's because
Understood?
appendicitis, the
Acute,
appendix is
acute
probably
appendicitis.
perforated or
Acute appendicitis may resolve on its own. It's called resolving
yes,
acute appendicitis. That you can say no complication. It is resolved. Patient has responded. Like probably if you think 6 months back, patient has had acute appendicitis, which has resolved on its own. That means it is no complication. But now it is not so. It has formed a mass. A mass itself is a complication. That's what Robinson is specifically telling. So your word with the no complication says that appendicular mass is not a complication. It is not so. It is a
Uh,
complication. Okay. But it is localized. It is a localizing sign actually. Okay. Right. Now, why is it is after appendicitis based on what clinical reason, and why is said it is appendicular mass? Why not appendicular abscess?
Sir, I have set it after an acute appendicitis episode because the person had 6 months back from the history. He
Okay.
had fever with similar complaints. Uh, at that time, also, I had not taken adequate medications. So, just to relieve the pain,
Okay. How old is the patient?
40-year-old, sir.
Okay.
And I have set it as appendicular mass mainly because of the age of the patient. It's about 40 years. And also because of this past history of having similar episode.
Okay. That's
And
only one
also,
episode. Okay. Okay. I've accepted. I'm not questioning.
uh,
Okay.
and also as I have ruled out other conditions in right iliac fossa, like tuberculosis.
Not ruled out. You are not fully ruled out. But only thing is previous history, current history of short duration, then forming a mass in short duration. You said it is surface actually smooth must be and localized mass firm it is tender you said. So all these features are probably short duration mass forming after an episode of acute episode. That is why probably it is a particular mass. That's what exactly you have to give reason. Now, how we will differentiate from the mass and abscess? That's a little tricky. It is said that abscess is rather lower down, and the lower margin is not very clear because you know that concept is anywhere pus comes to the surface. That's the basic nature of pus in the body. It always tend to come to surface. When it tend to surface, it also tend to come to the dependence portion. So naturally it comes to the surface and lower part. So lower border is not very clear, indistinct. Whereas it is a well localized one that we presume that it is appendicular mass. Second thing is it in the right fossa. Third thing is, it is the commonest right fossa mass which we come across as surgeon is appendicular mass. I think Robin, you will agree. I think no,
Yes, sir.
sir,
Definitely, sir.
Manoharan sir. Yes, so that is what you have to think of. But you need to put a differential diagnosis. It is not one diagnosis. It is sufficient. You need to put some differential diagnosis always in a right fossa mass. Okay.
Okay, sir.
So
So I think Shahna, yeah, your just for the sake of the listeners also, your most common differential diagnosis would be appendix based on anatomy, ileocecum, probably tuberculosis, probably
yeah,
three carcinoma, cecum, which is the anatomical thing. So
easy.
appendix, like you said, how do you differentiate between all these guys? Age of the patient, like you rightly said, young people, appendix on one side, middle-aged people, ileocecal tuberculosis, carcinoma cecum, elderly age
Elderly.
group. Then the chief complaints of the patient.
Duration.
Mass, yeah, the duration, and that is very important because Murphy's tried pain, vomiting, temperature, all these guys, depending on the severity, we can differentiate. In ileocecal tuberculosis, all these symptoms, not it's not very common, but what about the temperature? Evening rise of temperature is very characteristic there. Pain is not classic like here, which is calling it, but it is vague discomfort, which is always there. Vomiting, not normally present unless the patient is having complication of tuberculosis, which is obstruction, which I'm sure you know from theory. Carcinoma cecum, again, symptoms, pain, vague. It's dull, aching, boring sort of pain because it's some mass sitting there. Patient is having fatigue because of the anemia and all this bleeding and everything is happening. Vomiting, unless it's obstructed, which is again very rare. It takes a long time. But those are the chief complaints. When it comes to the local examination, inspection, palpation, percussion, auscultation. Of this inspection, all the three things to differentiate may or may not a mass may be present. Agreed. But palpation, yes, like you said, border, margin, surface, the consistency. And on one side, you have probably a soft to firm. On one side, you have firm to hard, and carcinoma cecum, you have hard. It's very easy to remember all this, all the
Yeah,
consistency.
this
Then
is a
the same thing. Yes, sir. So then you go to investigation and whatever you want, and yeah, medications, any history of medications or anything was given. Yeah, so it's very easy to note it. Yes.
yeah. In appendicular mass, we are supposed to mark the mass, and day by day mass will decrease. Whereas in appendicular abscess, it becomes larger, it becomes more tender, and will become more toxic.
Yes.
Yes.
With appendicular mass, you know that you have to treat at least initially conservatively. Many people may do surgery, but by constant, by principle wise, you have to wait. Whereas appendicular abscess has to be drained because it's a suppuration, it's a pus formation. So that is that logically they should have a clear clinical difference between a mass and abscess because mass is treated conservatively, abscess should be treated by drainage. Whether you remove appendix or not, that depending on the situation, that's a different thing. That's why this are different. This they need to differentiate it clinically. Of course, toxic features are much more relevant in appendicular abscess, where toxic features will not be there once a mass is formed. It's a localization phenomena. So then it is so naturally toxic features will come down. At least day by day it will come down. So that's what exactly appendicular mass means. Of course, cecal growth, lymph node mass, ileocecal tuberculosis, all will come as a differential diagnosis in any right fossa mass because one or other way they may present sometimes like this in acute presentation. Sometimes Crohn's disease may present as acute one, it's not uncommon. So like that, so many conditions are there in the right fossa mass which you have to think and then put it in orderly fashion what is more suitable to this patient at this age group. So everything comes, you are already told. All everything you have to compile, analyze, think, and put into the thing which is first, which is next, which is like that. I think Robin will go to the next slide. Or
Yes,
anything
sir.
to add also?
Investigations. Yes, sir.
Yeah. Next slide, Shreya. Shana,
Yes, sir.
Okay.
slide is
Okay.
with you.
How to investigate your patient? You have routine blood investigations. So you
Yes.
can, yeah. So CBC. So probably you will find in appendix. ESR, is it raised in both appendix, ileocecal TB? Both.
Yes, sir.
CRP, almost all inflammatory acute
All.
conditions, you will find that. Yeah. Hematuria, okay. In appendicitis, depending on the tip in the pelvic, if it irritates the ureter, that you have already said. Ultrasound and CECT abdomen. Ultrasound abdomen is the most common screening tool that you do for anything. Even for ileocecal, you'll get the lymph nodes also. It's very good. Yes. CECT is the gold standard for appendix, for everything. Yes, you'll get everything. Um, for historical purpose, is there anything else you want to add for if you have a differential diagnosis of ileocecal TB? You can't have CECT or anything.
So, barium enema X-ray.
Barium, barium enema or barium something else. Meal
Barium
follow
meal
through.
follow through.
Follow through. It's ileocecal tuberculosis. So
Barium meal follow
okay.
through with the barium enema, not just the
Enema.
barium enema.
Yes.
Okay.
Okay. So with that, you will get all your basic stuff, but that is not enough. What if you have a colon problem? C cup.
Sir, mainly with colonoscopy.
Coloscopy is the gold standard. You will get everything because not only can you see the site of it, you can take biopsy also, and
Biopsy.
brush biopsy is everything you can take. Okay, very good. Okay. Any other investigation if it is carcinoma C cup?
Uh,
Any relevant
Any
marker?
any marker? Sir has given
CEA.
clue.
See,
CEA. Yes.
what to do for?
Please remember. Please remember.
Carcinoembryonic antigen, sir.
Okay, what
Is
the
that a
normal?
normal? Is a normal thing or abnormal marker?
Sir, it is not a specific marker.
Because it is found also in benign conditions and inflammatory conditions
Uh,
also. But our
yes,
question
sir.
is it normally produced by the bowel or is it coming abnormally produced by the carcinoma only?
Uh, Sir, it is abnormally produced.
Please, Shahna, you have been seeing me for almost 5 years, no? So if I have to ask a question, always there's a trick somewhere.
That is
It is normally produced by the
normally.
colon.
So it is a glycogen related
Yes.
and normally produced by the colonic epithelium. Okay, colonic lining.
Okay.
Sorry, colonic lining.
And if it is tuberculosis, anything else you want to do?
Sir,
Just for the sake of finishing completion, so that everybody's listening, so that anything,
Mondo's
any
test.
no, Manto is it specific?
No,
A
sir.
patient
It is
in
not.
this generation where we are all vaccinated,
We all,
or
if
maybe
you
patient is immunosuppressed or immunocompromised.
be positive for many. If you have got a disease without any this one, bonds complex quite common, and we will get a positive this one. Understood?
So, barium meal follow through can be done in
No, that we
tuberculosis.
have done. Now we are talking about any other investigation. Imaging is over. You're done. Imaging is over. Anything else?
Anything relevant recent thing? Yeah, of course you have to do a chest X-ray, primary focus, all the things are there, or CT chest.
Because you do realize that it will not ileocecal will not come de novo. It has to come from the lung. Patient is swallowing the
Yeah,
sputum. The bacilli is coming down, sitting over there, and growing and becoming there. You know that, no?
it
The
has
Yes,
cycle
sir.
are here.
it
Yeah.
should be
So
secondary tuberculosis.
Chest
yeah.
X-ray.
Chest X-ray is done. Sir Parjo. Sir has said that chest X-ray taken for the ruling out primary TB. Okay.
Sir, we
What if
can.
now you're in the abdomen? You're in the abdomen. Is there anything that you can do? Sir has asked some specific thing. It is there in Pushperi also. That the lab it is there.
Sir,
During COVID time we have used it. That time it was installed.
PCR.
PCR.
Yes,
PCR when it is more
Yes.
faster now, but not like before where you have to check for sputum, take years together to get the thing. No, you have PCR now. What if you have a distended abdomen and you are
Sir,
suspecting ileocecal tuberculosis?
ascitic
Asset.
fluid,
Fluid
AFP bacillus.
analysis. Yes, very good. In ascitic fluid, what will you look for specifically? Answer it very carefully.
Uh, so, protein.
A protein in tuberculosis, what protein you will get? Transliterative or exudative?
what to specifically look for?
Sir, I'll specifically look for AFP bacilli,
Okay.
acid fast bacilli in ascitic fluid.
May not be, may, but if it is there, yes. If it is not there, you won't be able to say it is not even
Yeah. No, something else.
only.
Serum,
What is the specific thing you look for in that?
albumin.
What
Serum
gradient?
albumin gradient, it is there is a protein, it is exudative protein. Okay, we agree. But something else, something specific we are looking for in the ascitic fluid. It is very high in tuberculosis. The minute you send these two guys, it's pakka.
Very high.
Sir, ADA, adenosine
ADA.
deaminase.
That's it. Adenosine deaminase and LDH.
It will be very specific.
They're very, very, very grossly elevated. Okay, about that's fine. Yeah. Okay. Sir, anything else? I think we have
So,
covered all the three just in
third
quick
one
fire
was
pattern.
colonoscopy, she said, but you may, because it is acute episode, you may have to wait for a few days, then go for colonoscopy you are suspecting. The different thing
Yes.
when you start. Next, we'll go for you have to mark the mass if you are thinking a
Yes.
particular mass. Then you have to do ultrasound daily basis, whether it regressive or increase in size. Where you have to. Next, let's say, yeah. So
Shahna,
treatment plan.
just when you write the notes, you just put a note also on diagnostic laparoscopy also.
Yeah,
If
laparoscopy
Yes.
it
also.
is, it is there in Sir's book also. The last point he has added it. You go inside. If you have any doubt, you will take the peritoneum. You can chop off and send it for biopsy.
Biopsy.
Because it will be very thick. If you see it once, you will never forget the TB peritoneum. It is like cutting a rubber sheet. In Kerala, you've seen rubber sheet, no?
Very
It's like
thick.
it's that it is very thick. I mean, knife will not go. You need scissors to
Very,
cut.
very thick in the abdominal
It's very
tuberculosis.
thick.
Peritoneal tuberculosis. Okay. That's why
Yes.
you see the Dowie abdomen. Okay, very thick abdomen. So you said the
Okay.
Oscar Sharon regime, initial aspiration, all those things anyway they can read. Marking mass is very important. She has mentioned actually. Antibiotics,
Yes.
of course, after 3 to 6 months interval appendectomy. So Oscar Sharon regime is a common short note asked. So treatment at
Okay.
least in
Yes.
appendicular mass. So by principle, it is a conservative initially. But the important thing is you
Yes.
have to advise interval appendectomy at a later date. Again, additionally important thing is you have to rule out other conditions, maybe tuberculosis, maybe carcinoid, maybe carcinoma cecum. Such things may happen. So that also you have to keep in mind before concluding that it is appendicular mass and appendicular mass only, not anything else, because there are so many conditions which can cause present as a rectal fossa mass. That is so many conditions. That's why that is very relevant. But appendicular mass is the commonest one. So your diagnosis at this stage, first thing with the short duration or common thing comes first. So appendicular mass is the first diagnosis, but you should be able to give some differential diagnosis in the rectal fossa mass always. So that also like carcinoma, yellow cycle. We have discussed all those things. So lymph node mass, those things. And
Yes.
regional lymph node won't come unless it is added to the abdominal wall. It's already Robin has specifically told about that. Okay, so that is the treatment plan.
Yes.
So next slide, Shreya. So
Okay.
that is so mass, right fossa mass is very important thing. Uh, other things also we may discuss, Shana. They may discuss if it is a carcinoma, what you will do. If it is electrical tuberculosis, what you will do. You should be able to give an answer, treatment strategy. They will not ask uncommon thing, at least carcinoma, electrical tuberculosis, appendicular mass, some lymph node mass, what it could be. Then you should be able to give answer, not just appendicular mass, even though it is common. Probably is the right diagnosis in this patient. And your photo shows very clear mass actually. Understood? So I'll just go through the slides, Robin, if you permit. She
Yes.
has
Yes, sir. We have
presented well.
time. Yeah.
Sana, she has
We are
presented
done. I
well.
think.
You have discussed well. Of course, mass abdomen is a very difficult topic because a lot of things, because you know that Pandora's box, mass abdomen is a Pandora's box. So you think so many things, finally it will be something else. So that's what exactly. So you have discussed, presented very well, Sana. I'll just go through the slides, Robin, just to
Yes, sir.
highlight.
Yes, sir. Yes, sir. Yes, sir.
So that is the go to first slide, there. Okay, next slide. This is the regions. You have to remember different regions are different from the quadrants. So I'm just going to say, right. So these regions you should be able to remember. And masses, different anatomical structures are deeper to this region. So that is also important. This picture is very, very important to have idea what mass comes from which anatomical organ. So basic thing, it gives a basic idea. So this picture is important. Next slide. This is the quadrants. See that right, left, right. This the quadrants are different. Little meanings are different. Regions are different. Lines are different. This is just straight line, whereas regions different lines are there, and only four quadrants again. So when you say quadrants, when you say regions, your meaning, technical meanings are different. Just want to mention that. Next slide. So history, name, age, occupation, residence, same things. Next slide. Chief complaint: mass, rectal fossa, pain, bowel symptoms, fever, appetite, weight loss, all those things we have discussed. Just I put in the slide. Next slide. So orderly, chronological order. Robin has told clearly, Shana, chronological order is important. Accordingly, put it that that is being
Yes.
discussed actually. I just put in again mass, duration, pain, fever, other lumps in the abdomen. Bowel symptoms, colicky pain, other thing, diarrhea, blood in the stool. We have discussed all those things. Jaundice, white is relevant if it is carcinoma cecum YB. So urinary symptoms, again, we have discussed metastatic symptoms if you are considering malignancy. Toxicity of mass and treatment for that, you already told. Tuberculosis, spine disease. Again, spine disease, sometimes psoas abscess comes there. And commonest cause for psoas abscess, other than bacterial, is the tuberculosis, spine tuberculosis from psoas abscess, swelling in the right fossa, and sometimes extend down into the below the inguinal ligament. And possibility of treatment and surgery, again, you have taken drug intake, mainly anti-tubercular drugs. That's also important. Diabetes, spine disease, malignancies. Family history, we have discussed it again. Runs in family, colonic carcinoma. So diabetes, malignancy, treatment history. In female, menstrual history, operative history. That's important because ovarian mass and ectopic pregnancy in young females, and other fibroid which is projecting towards the right side. There's so many conditions specific for females. So female patients, this history is very relevant when you consider right fossa mass. Okay, so next slide. Uh, just putting the body weight is very important in abdomen mass because significant body loss of weight in 6 months, short duration, 10 kg loss of weight in short duration is very relevant. Significant weight loss. That's what the meaning of significant weight loss. That's very important. Next slide. So local examination, again put it in the table actually. All things we have discussed. Lying down position, later after standing, and counter of the abdomen. Whether it's a fullness, we have mentioned, I think, in the inspection, visible mass is there. Sometimes well localized mass may not be there, then you take fullness. Fullness is seen in this region. Then eventually, when palpation you tell, it is palpable mass is there. That's why this fullness word is often used when you are not clear about the clarity mass, which is not visible on inspection. Fullness is a common thing observed, I think. Robin will agree with me.
Yes,
So
yes,
that is what word we can be used when it is clear cut mass is not visible on inspection. But palpation it becomes. So if it is mass, fullness, everything, extent, shape, size, approximately, you have to mention expiration. Movement of the respiration is very, very important. Pulsation, impulse on coughing. Sometimes it is very important because there may be herniation, all those things. Umbilicus, we have told. Daniel sign, everted, everted, inverted. Dilated means always check in standing. Flanks full or not, maybe due to ascites, other things. External genital is important, testicular tumor. Undescended test is present as a mass in the right fossa, maybe abdominal tumor, testis gone for a testicular tumor. Pulsation, iliac artery aneurysm, visible peristalsis in obstruction. We have discussed that. Loin should be inspected from behind, it's important. In sitting position, from behind, you should inspect the loin for fullness. Okay, if there is a fullness, there is something, some renal pathology is there. Pressure effects, mainly there is obstruction. Local rise of temperature under effect, palpation of the mass, size, shape, extent, margin, border, surface. The surface is very important. We have discussed surface after the consistency. I should come first actually. Movement with the respiration. Sorry. Then mobility and fixity. After that, mobility and fixity of the mass. Understood? Movement with the respiration, mobility and fixity of mass. Head or leg raising connect. I have told intrinsic mobility. We have discussed. Once it is non-mobile, you have to say fixed to what? And that's how we say abdominal wall or intra-abdominal rectoabdominal mass. Versatility is still plane of the mass, intra-abdominal. Sometimes there is a confusion, I think, Robin. Intra-abdominal, intraperitoneal, all those things. I
yes,
think
yes,
intra-abdominal, if you say that is sufficient.
yes,
That is fair enough. For the liver and other muscles, we already discussed renal angle tenderness in sitting position. And if it is thinking that this mass is extended to the lower or lumbar region, then you have to do the bimanual palpation and ballot definitely. That's what you have to keep in mind. Now, percussion, remember, always you should, liver dullness should come first. That is the guideline. So, without mentioning liver dullness, your percussion presentation is will be wrong. First thing liver dullness, then percussion over the mass, percussion over the free fluid. Then, if relevant, if required, then percussion over the renal angle in sitting position, foresight. Normally, renal angle is resonant. It contains not kidney, it contains descending colon right side, descending colon left side. But when kidney enlarges downwards. So it pushes the colon in front and medially. So normal resonant renal angle becomes dull on percussion. So renal angle dullness is pathological. Resonant renal angle is normal because normally it is occupied by the colon, not kidney. So renal angle is normally resonant. Many students get confused. So if it can become dull, it is pathological. That point is very important. Next slide, Shreya. So this is dilated veins standing you have to look for. There's a mass in the mass here, extending here. Left suprachicular, just wanted to mention how left troisier sign or uh, virtuous note, how it is visible. Okay. Next slide. So other exam we already told Boylston's, Brui, rectal exams important. In females, for vaginal examination may be required, especially you said is right fossa mass. Lower abdomen mass is important. And examination standing position in upper abdomen mass. And examination after emptying the bladder in the lower abdomen mass. Very, very important, especially in females again. You have to examine the mass in empty bladder. It's very, very important. Suppose the patient can't pass the urine completely, then pass the catheter, then pass the examine the mass again. That's important. The lower abdomen mass. And systemic exam, spine exam is very relevant because our have the tuberculosis, everything becomes very relevant at least in inflammatory abdominal conditions. So that's why it is also important.
Give us deformity and paraspinal spasm.
Also, yeah, gibbous deformity and paraspinal spasm. That's what you have to look for. Absolutely right. So next slide. So differential as parietal swelling, we classify the abdominal wall, tumor, wall abscess, iliac abscess, appendicular abscess extending into the abdominal wall. Usual appendicular abscess is intra-abdominal, but it may extend to abdominal wall, becomes abdominal wall. That's what I said. Then edema will be there. Actinomycosis in the right fossa often extend to abdominal wall and may form discharging sinus with sulfur granules. That's not common now, but once in a while it may come across. Not very common. Next slide. So intra-abdominal peritobudal masses, appendicular mass abscess comes first. Carcinomosecum, myelocele, you have discussed that. Amoeboma, which used to be quite common when we were postgraduate 35 years back. Now, of course, because very common use of metronidazole, it is not become. Otherwise, we used to see such now not common. So, what still can occur. We have seen, we see, especially spine tubercular functioning thoughts have this. Lymph node mass not uncommon. Remember, mesenteric and iliac node mass, iliac node mass. It may be lymphoma, tuberculosis, non-specific also. And bony swelling from the any chondrosarcoma or fibrosarcoma arising from the iliac bone. Ectopic kidney, again important. Ectopic kidney presents a lateral force on non-mobile mass. Understood? I have seen patient getting operated and ectopic kidney thinking that there's some pathological and normal ectopic kidney is removed. So it should not do that. It's a criminal offense. So you should keep in mind. Undisseminated testis presenting as malignancy also. Actinomycosis already told. Next, such as the different. These are the four things we have discussed. Four, five things. That is important differential diagnosis. Appendicular mass, carcinomycosis, myelocele, tuberculosis, lymph node mass, which already we have discussed, I think. So now we have
Yes.
discussed. So next slide. So just going through that, we can go through later. Appendicular mass, how it becomes. Usually it is resonant on percussion because ileum comes there, it get dilated because of inflammation. But it can be dull if momentum is the main component, it becomes dull. Understood? So it can be resonant or dull. Whereas abscess is always dull on percussion because first come to the surface. Very tender, they'll be toxic. So this is a look actual, there is no clear border here. It's a well-defined border, mass and abscess. Difference is there. Next one. I'm not going to read. I'm not reading anything. I don't read. Don't want to read. Just remember nodular, hard mass. That's important. Carcinomosecum. Initially it is mobile, but once it fixed to the posteriorly comes out of the serosa, it may get fixed posteriorly to the psoas major muscle, then becomes non-mobile. So it is impaired resonant. See that's what Robin has asked about. The percussion is very important in abdominal mass. Of course, anemia, anorexia, loss of weight is very common. Obstruction is not common in carcinoma of cecum. It do can occur. That's common in the left side. Ileocecal pulled up cecum. Is that pulled up? Cecum may be pulled up. That's what due to fibrosis. That's what Robin has already discussed properly. So other things also important. It won't move in the respiration because of fibrosis and adherent. Amoeboma used to be quite common, not very common, but it subsides. Inflammation is called as amoebic typhlitis. Spelling mistake is here actually. Sorry, typhlitis. Typhlitis. Okay. So next slide. Crohn's disease, this what not uncommon. Crohn's becoming more and more common. Present as a mass in the renal fossa. Mesenteric lymph node mass. Ileocecal abscess. Still, it is quite common. We see many times orthopedician, spine surgeon refer the patient to us to drain this one. They will have so paraspine psoas spasm. See that gibbous tenderness, paraspine spasm. Already, Robin, you have told these things. And the psoas spasm with the flexion is quite very typical of the ileocecal abscess. We see regularly, we drain these sepsis quite commonly, so not uncommon entity. Sometimes they extend across the inguinal canal into the below, and then you will have a cross fluctuation. Swelling below the inguinal ligament, above the ligament. It's called not standard fluctuation. They're called across an anatomical barrier. That is called a cross fluctuation, like compound palmar ganglion, ranula, plunging ranula. They're fluctuation in the two anatomical across anatomical barrier, bilocular hydrocephalus. They're the four conditions which are cross fluctuant. They're not a standard fluctuation across an anatomical barrier. So that is one of the things. Next slide. So iliac lymph node mass is a deeply placed, non-mobile, nodular, maybe hard, maybe smooth. If it is smooth and large, maybe lymphoma. Nodular, maybe secondaries. Uh, Understood, maybe tuberculosis also. Acnomic is already told, forms a mass, get adherent from the discharging sinus. Ectopic kidney. Kidney, you know that kidney ascends, testis descends. That's the usual thing we remember. So kidney fails to ascend actually, then stays in the usually the sacral region in the retinal fossa as a typical mass. It is usually pathological, maybe hydronephrosis, pyonephrosis, carcinoma, polycystic kidney. Everything can occur in the ectopic kidney. So next slide. Undescended testes are already told presenting as a carcinoma. Pelvic masses, especially in females, ovarian tumor, cyst, tubular mass, uterine fibroid, pyosulfate, gold ligament cyst. Everything can present as a right fossa mass, especially, of course, always in females. And you should do a pervaginal examination and empty the bladder is very, very important. It's already told. Emptying the bladder is most important in lower abdomen mass, especially in females. And other masses, round worm bolus, especially in children. Mobile kidney may be there in the lower region, may come down. Hydrops, gallbladder, big gallbladder feeling in the rectal fossa. Urinary bladder diverticulum, retrobutral masses, soft tissue tumor, bony mass like chondrosarcoma. I like art aneurysm. Again, you have discussed Robin, pulsation, everything you have discussed. So the other masses which can show rectal fossa mass is the main question for them. Sometimes short notes enumerate rectal fossa masses. So let them write common thing first, then this one. If a main question comes, lead to features they have to tell, I think. Small, whatever I mentioned, briefly they have to mention. Next slide. So this is, remember this detailed history, inspection of entire abdomen from side and distal end, palpate mass from all findings, plane, everything or discussed, and existing change of position. Palpate mass in the change of position, especially in the abdomen, is very relevant. After emptying the bladder, I was told, inspect, palpate, percussion, renal angle, sitting position. Renal angle is the examine in sitting position, remember. Percussion in is very crucial. I said, we all discussed that. Liver dullness, over the mass, free fluid, ascotrophy for breathers, and digital recognition is very important. You have to mention in the exam, may not do it, but write always. Rectal examination not done. But what you want to look for, you should mention. That's important. Maybe secondary is Blumer shelf, ulcerations, sphincter tone, all those things. So left suprachiasmal lymph node mass already shown. System with the spine, everything. Management, blood, CET, guided FNAC, system surgery, conservative treatment, depending on the situation. Of course, you can refer my clinical methods. Next slide. So thank you very much for everybody, Robin. My book,
Yes.
Clinical Method Surgery, is there. I request all students to use of it. Video is there, how to examine. My manual is there. My operative surgery is there. My main request is to subscribe my YouTube channel. So make use of it for daily lectures. Uh, Shahna, you can tell your friends and colleagues and students where you meet, subscribe
Sure,
the
sir. Sure.
daily thing. And Sana, you have presented well. It's a difficult thing, lateral fossa, not that easy. It's a postgraduate case, actually. Of course, Robin always discuss in a very systemic way, analytical way. It's very good in that. Robin, again, thank you very much for joining. I
Thank
took
you.
your time, more than 1.5 hours.
No, 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 no. Actually, we took a small short break for Christmas and New Year, sir. Now we are back to action.
Okay, mass abdomen, lateral fossa mass is a very common thing.
Yes,
I
yes,
think
sir.
it needs extensive discussion. They should know.
Yes, yes, yes. It's
So,
very common. RAF will be kept for the exam.
students have to know.
They have to. Yes,
Thing,
it's
because basically it's analysis. Analysis, that's what exactly. So, Shana, you have presented very well with the presence of
Thank
my
you, sir.
representative. Of course, every question we can't answer. Some question from Robin, I also was not very sure. But, it's the depth of knowledge is very genuine. So it was a good discussion and a very common case kept in the exam for all students.
yes,
Analysis for mass abdo is very, very important for whether UG or PGs whenever they come across mass like that. So I think most of the things we have covered, it will be definitely useful to whoever students go through this one. I request everybody to go through this one. Robin had a very good
yes,
discussion. Thank Manoharan
yes.
sir.
Thank you.
because
Yes, sir. I think once he's
not
back from
communicate.
exam, it will be better, sir. I think that it's very difficult with the range, sir. Yes, phone, it's
He
very
was not
difficult.
in his place, but still he tried to
Yes,
communicate contact. It's
yes,
very
sir.
nice of you. Despite of
Because
busy
yes,
schedule, he wanted to join. I'll call him and speak to him. And
yes, sir. Yes,
Robin,
sir.
very nice of you for joining. Good discussion.
No, no, no.
It will refresh me also for a lot of things.
Yes,
So next week, 15th, we'll join for salivary
yes, sir.
gland,
Salivary gland. Yes, sir.
salivary gland examination.
Yes,
Sana,
sir.
tell everybody to join. Let them give opinion, whatever they want, how they felt about the live discussion, and request them everybody to subscribe my channel because daily small lectures are, especially for students, it will be useful. Uh, Robin, thank you very much. It is very nice.
No, thank you, sir.
Just
Thank you,
two
sir.
two
Thank you, sir.
minutes to tell conclusion words, Robin. Uh,
Yes, sir. Sir, while we were discussing, you were asking. I went through the YouTube channel. I put the questions, few of them.
okay,
So if any doubts is there, they can clarify later, sir. It's okay.
okay,
Shahna, very good presentation. Sir, she is one of those few students who are always behind me, always take class, take this, take that. Okay, so they are
no,
very
she
motivated
presented very
batch.
well. She,
They are very motivated batch. Yes.
this
This,
we can't answer every question, because subject is very
yes,
vast.
sir. RAF is a little bit difficult, but she could answer all the common questions set for UG exam. We went a little bit PG level because she was answering. That is why I asked. That's all. But sir,
Many
actually, this
questions
case
are
we are planning for surgery for this case. I did a small mistake. I didn't take the photograph properly. Actually, there was a big mass. It was very beautiful, like in textbook,
one photo
with
only
all
comes
the
big mass.
borders and all that.
It's quite
And
big.
the next day, when they came the next day to examine, it became flat. Within
That's
24 hours, it became
that's
the
what
mass just reduced.
regresses.
Yeah.
Appendical mass regresses so fast. In 4 5 days, mass will disappear. That's a
It
usual
is
thing.
very magic. It is very good case, a classical textbook case for when he came to the OP. It was a mass only. So students who were there, they saw it.
And
But
definitely
yeah,
exam case. Definitely exam case.
yes, sir, yes, sir, yes, sir.
So
So it is a very good presentation, sir. I am
good
sure
presentation.
they'll do well.
Well done.
Yes,
Very nice. So thank you, Shahna. Thank you, Robin.
Thank you, sir. Thank you.
thank you
Well
so much.
done,
Thank
Shahna.
you, sir.
Well done. Tell everybody to join also. Hope everybody enjoyed it. Robin, again, thank you very much. We'll
Yeah,
meet
thank you very much, sir. We'll meet
next
next week, sir,
week, Wednesday,
for parotid. Yes, sir.
10 p.m.
We will try to cover abdomen, sir. A lot of few cases I have prepared for the students, so
Yeah.
we can finish off because abdomen
Well, yeah.
they will get for the exam.
And
Yeah, the other things they are almost ready.
yeah, and thanks to Shreya because back from the backup of everything she is doing on my behalf. I just come
Yes,
and join.
thank you very much, Shreya and Adi. Yes,
Yeah, Aditya, they do everything background.
yes,
So
sir.
this is my QR code for joining thing, everything. So thank you very
Yes,
much. Good night again. Well done, Shreya.
yes.
Thank
Thank you,
you.
sir.